Well, let's talk about management, and with the rest of the talk today is going to really focus on novel therapies and novel targets. But let's remind ourselves what are the goals of management of asthma. It's not just lung function improvement. It's really more improvement of symptoms, decreasing impairment, decreased need for rescue medication, decreased need, improvement of lung function is important. Don't take me wrong, but also we want to improve exercise tolerance and quality of life, but importantly, we want to reduce risk and risk of exacerbation, hospital admission. Ultimately, we want to reduce hospital admission and mortality. The good news in the United States, at least, mortality of asthma has gone down recently, but we still lose about 3,000 patients a year in the United States for asthma. It's not a large number, but it is a disease that can be treated and controlled, and we really need to strive how can we prevent or reduce this even further. Well, there are several goals, and when it comes to severe asthma, and this is really focused, there are several buckets, as you see on this slide. I'll try to go through these quite quickly so that we can talk more about what's new out there. Obviously, one of the very first thing you want to know when it comes to pharmacologic therapy is to optimize the inhaled steroid and a controller therapy. That's very important. Make sure the patient is taking the dose and going up on the inhaled steroid. Uh, uh, can help, although there are multiple studies now showing is in patients who are in impending exacerbation, doubling or quadrupling inhaled steroid does not really do it, and some of these patients need other things. I'll briefly talk about oral steroids in a minute, but there are other potential therapies that need phenotyping. We'll talk about how we do it with the biomarkers we have these days, and then there are obviously non-pharmacologic therapies. So add on without phenotyping, or are there certain medications where I don't need to phenotype patients where they work? I think one of the recent additions to the armamentarium we have are the long-acting anticholinergics, in addition to the inhaled steroid LABA. These are important drugs that have been shown in multiple clinical studies that you don't need to have, they don't just work in eosinophilic or allergic, they really don't need any phenotyping. What about oral steroid? We all know the horrible side effects of oral steroids, and indeed, we strive in our clinics, and I'm sure you do, to try not to use oral corticosteroids. Indeed, when you look at the different guidelines, whether the NIH guidelines, the ERS ATS guidelines, or the GINA strategy for management of asthma, I won't read this, but they all really warn us about the side effects of oral corticosteroid. They all advise us to use the minimal dose possible and to monitor for side effects. Indeed, there are several papers, one just recently published in JACI. Uh, these are from claims data analysis, large cohort, observational obviously, but looking at even patients who need 4 or more courses of oral steroid in the preceding year, and they looked at comorbidities associated with this. We think that only patients on continuous oral steroids have problems. Actually, in that analysis, it showed that even 4 courses a year was linked to increased odds ratio of having several of the comorbidities associated with oral steroids. So keep that in mind when you see these patients who require regular courses of oral steroids to control their disease, or those on continuous oral steroids, to look at other avenues. What can I do for that type of patient? So there are certain treatments where we need to do phenotyping, which I'll talk about in a minute. But before that, I want to mention an important non-pharmacologic approach is in some patients, although we still have not identified that phenotype who would respond best, is bronchial thermoplasty and obviously managing other comorbidities such as depression, anxiety, and other things that can be done non-pharmacologically as well. But what about the phenotyping? There are strategies using sputum guided approach. Obviously, that's good, but not very practical. It's been shown that if you measure sputum eosinophils and escalate the dose of inhaled steroid or start something that target that, you have a better outcome than just using your clinical sense of control or assessment of control. uh, so phenotyping has been something that we are pushing, but to do so really rightly, you need some biomarkers, tools that you can use in the clinic. Nobody expects us to do sputum induction in every patient, although in some specialized centers they do. So we really need something practical to measure, and biomarkers really are important. Now we're very, very early in that field because we only have few biomarkers, all of which reflect what Trey mentioned, T2 airway inflammation. We don't have good biomarkers that reflect the non-T2 asthma. Uh, some of the biomarkers we use, although the last one, periostin, is really in research right now, is not available for us to use, but some of these biomarkers have been utilized actually to look at more targeted therapies of asthma. Uh, IgE obviously is important to identify allergic asthma, although the level of IgE is not a good predictor of effect for anti-IgE therapy. It is important to measure, to not only dose but to predict who would need it, would need an anti-IgE therapy. We'll talk a lot about eosinophils in a few minutes, and blood eosinophils have been shown to correlate nicely with sputum eosinophils in the proper context. I have to preface this because there are lots of issues with blood eosinophils, when to measure them, how often, do they have confounding effects. Neutrophil sputum is not really a very good biomarker, and actually it's not really the best to identify non-T2 asthma. Exhaled nitric oxide is re-emerging. It's an important biomarker. It's a very good T2 biomarker. It's not only predictive, but it has a prognostic effect, just like eosinophils do. The higher the FeNO at baseline, the higher risk of exacerbation. But also, it is a good predictive of response to certain agents, like inhaled corticosteroids, but also drugs that target IL-13 pathway. And it's also a pharmacodynamic biomarker. The levels of it come down with treatment, like with inhaled steroid, with drugs targeting IL-13. It is not, the levels are not affected with drugs targeting IL-5. And then periostin is still in the pipeline. Whether it comes to fruition that we can use in the clinic is still unknown, but it's a very good serum biomarker that reflects IL-13 activity. We have toyed around whether such biomarkers can reflect response, and one of the very first papers we published was an exploratory study looking at our data from the extra study, which was looking at the effect of omalizumab in reducing exacerbation. And indeed, at that time, this was published many years ago, we showed that some of these T2 biomarkers actually indeed reflect, if they are high, reflect better effect from an anti-IgE therapy, omalizumab in here. You can see that FeNO, high blood eosinophil, and we did have some patients where we measured serum periostin. Do they stand up, this type of thing, or predictors in real life? Well, in with omalizumab, a more recent study, a real-world study, actually did not show that eosinophils really predict response to omalizumab therapy. In this French study, this was observational, real-life type of study. They showed that whether the eosinophils were high or low, the effectiveness of omalizumab was similar. So we need to do more studies on biomarkers to predict or at least define their exact role when it comes to targeted therapy in asthma. So talking about targeted therapy, we're going to shift gears now to talk about specific drugs. What do we know, and what do we have right now, and what may be coming? You can see that some of these biomarkers are approved. The anti-IL-5s, Dr. Panettieri is going to talk about. I'll mention a few things about omalizumab, which is an anti-IgE, and I'll talk a bit about dupilumab, which is an anti-IL-4 receptor, which is not approved yet, but maybe soon. We want to talk today about another biomarker, another targeted therapy, tezepelumab, which is an anti-TSLP. It is in phase 3 trials, and then there is a small molecule, not really a biologic, fevipiprant, which is a DP2 antagonist, also in phase 3 trial, which may be coming, hopefully, for patients and for us to use. What do we know about these biologics? As you see here, I won't go through the details of this table, but we are going to focus on these approved drugs today mostly, and show you what are the clinical data, the safety, the efficacy of these agents, and you can see the approval indications in this table.